evening, students. Hope you all are doing. Good evening, students. Hope you all are doing well. My name is Dr. Srishty Chaudhary. Starting with a brief introduction about myself, I own a degree in obstetric and gynecology. Currently, I am pursuing my MCH in reproductive medicine. Let me introduce you to the subject. Obstetric and gynecology is quite important from your NEET PG exam point of view, as out of 200 questions, around 30 questions are from OBG itself. Plus, the syllabus is not vast as medicine, so it is quite scoring as well. So during our teaching, my main focus will be on explaining core concept and telling you about key points related to every topic that will help us solve most of the MCQ. Okay. So starting with today's class, my topic is mechanism of labor. Now starting mechanism of labor. What do you understand by labor? Labor is a term which tells about the process of birthing. Okay. So process of giving birth to a fetus, the term used is labor. Now we know from our basics that there are three stages of labor, right? Three stages which include first, second, and third. So first stage start from uterine contractions begin. Okay, so the uterine contractions begin, which causes a series of changes in cervix. So cervix undergo dilatation and effacement. Dilatation and effacement. So cervix, which was earlier completely closed, that the cervix was uneffaced and the os was closed, undergo series of changes, and there occur full dilatation, which gives way for the delivery of baby. Next is second stage. Second stage is delivery of the fetus. So the fetus is delivered. Next is third stage, in which after the delivery of fetus, placenta and membranes are delivered. Okay. Next. So this first stage is divided into again two phases, which is latent phase and active phase. Now there's something called as normal labor. So what do you understand by normal labor? For a labor to be called normal, there are certain points which are or certain criteria which are to be fulfilled. So it must start at full term gestation. So full term is 37 to 42 weeks, right? Next is the onset and progression. Both should be spontaneous. Okay. So the onset and progress both should be spontaneous. Next, the baby. Babies should be in cephalic presentation. Attitude should be complete flexion, and presenting part is to be vortex. Now, as we already talked about, first stage has two phases, latent phase and the active phase. So how do we define latent phase? So as per WHO 2018, latent phase start from undilated cervix till 5 centimeter dilatation. And beyond that, it is called active phase, right? So is there any time limit for which the female can stay in latent phase? No. So they haven't given any time limit for this. In active phase, they have given a time limit for primary gravida patient. It is that the labor active phase should last for less than 12 hours. For a multi patient, the labor should last for 10 hours. Active phase only I'm talking about. Okay. For a labor to progress, there are three P's which should be normal. So first one is power. Second one is passage. And third is passenger. So what do you understand by all 3 points? So power. Power of what? Power of uterine contractions. Okay. Power of uterine contractions. Next is passage. Passage. What is the passage? There is soft tissue, there is hard tissue. So bony tissue, bony structure, which is the pelvis. So the passage labels is the pelvis. Next is passenger. Passenger is fetus. Okay. The passenger is fetus. Now we'll briefly talk about each of them and then we'll come back to our topic. Now starting with power. Power of uterine contraction, how do we measure it? We measure it by cardiotocography. Cardio is monitoring of baby heartbeat and toco is monitoring of contractions. So what we do? We plot this, the CTG, we take out CTG of at least 10 minutes. So in that 10 minutes, what we look for? We look for the number of contraction and their strength. How do we calculate the strength? We take the amplitude, we take the baseline and subtract it. So we get the strength. Over the 10 minutes period, how many contractions are occurring and their strength is added together and we get the strength of contraction, which is in Montevideo units. So for calling contractions to be adequate, how much Montevideo unit should be pressure should be present? The cutoff is 200 Montevideo units. So this patient is having 242 Montevideo unit pressure contraction. So yes, she is having adequate contraction. Next comes the passage. So passage is the pelvis. So pelvis is divided into two parts. The upper half, which include our iliac blade, that is the false pelvis, and then comes the pelvic inlet or the pelvic brim, and the area below this pelvic inlet is the true pelvis, and this is of obstetrical significance, right? So pelvic inlet has certain borders which we already know about, so that's a separate class. We'll talk it about later. Now coming to pelvic cavity, the pelvic cavity is the structure which is present between the pelvic inlet and the pelvic outlet. Okay, so there are two planes which are important in this. The first one is plane of greatest pelvic dimension and the second is least pelvic dimension. Greatest pelvic dimension, it starts anteriorly from the posterior surface of pubic symphysis middle point to the junction of S2 and S3 vertebra. Okay. Next is the plane of least pelvic dimension. It starts from the lower border of pubic symphysis, then crosses iliac spine, ischial spine laterally, and finally to the last sacral vertebra, which is S5. Okay. Now this plane of least pelvic dimension is also called as obstetrical outlet, because if the baby passes through this plane, then the baby will deliver for sure. Okay. Next is pelvic outlet. Pelvic outlet, it is a diamond shaped structure or the plane we can say. So anteriorly it is bounded by pubic symphysis, anterolaterally by ischiopubic ramus, posterolaterally by the sacrotuberous ligament, and posteriorly by the tip of coccyx. Okay, so this is pelvic outlet. For a pelvis to be called adequate, these are the diameters which should be present in the pelvis. If any diameter is less than this, then the pelvis is called to be inadequate. So this is a very simple formula for a pelvic brim or pelvic inlet. AP diameter should be 11/12 and transverse 13. For cavity, the normal diameters are 12 in all the dimensions. For outlet, AP diameter is 13 and transverse diameter is 11. This is in itself is a separate class, so we'll not discuss in detail about this. We'll just see how we have to clinically assess whether the pelvis is adequate or not. So we look for obstetric conjugate to assess pelvic brim. To look for the cavity, we look for pelvic side walls. Okay. We look for ischial spine, whether they are prominent or not. And we look for greater sciatic notch. Okay. For outlet, we look at the subpubic angle, for which what we do a 4-knuckle test. We see whether the 4 knuckles of our hand are able to fit in that subpubic area or not. Okay. So starting with topic. Now we are coming back to the topic, the mechanism of labor. So these cardinal steps, which include engagement, descent, flexion, internal rotation, extension, then restitution, external rotation, and expulsion. This itself is a previous year question. So they asked, arrange the following in the order of series. So they gave various options, and then they asked that which step occur first and which follows it next. Okay, so this was a previous year question, and this is the mnemonic which you can use to remember this step. Now coming to first step, which is engagement. What do you mean by engagement? So when the largest transverse diameter, which we know is biparietal diameter, crosses the pelvic inlet, this phenomena is called as engagement. Okay. And the anterior posterior diameter that will be entering the pelvis will depend on the presenting part. So that depends on the attitude. What is the attitude of fetal head? So on that, it will depend what is the presenting part. So in primigravida, the engagement occurs at about 38 weeks, and in multigravida, it occurs at labor onset. So what is the most common cause of non-engagement? It is a deflexed head, which is occipito-posterior position. Okay. Now, if the presenting part is vertex, the engaging diameter is suboccipitobregmatic. If it is face presentation, the engaging diameter is submentobregmatic. For deflexed head, the engaging diameter is occipitofrontal. For face, partial extension it is submentovertical, and for brow presentation, it is mentovertical. And we see this is the largest diameter, which is even larger than the pelvic diameters that we just right now saw. Okay. So here is the image which is showing the diameters which we already know about. So the most common engaging diameter is suboccipitobregmatic, and the most common engaging just a minute. Yeah. Suboccipitobregmatic is the most common engaging diameter, and the most common presenting part is a vertex. Okay. So this is an image which is showing our transverse diameter, which includes biparietal diameter, super subparietal diameter, bitemporal diameter, and the other one is bimastoid diameter. This is the largest biparietal diameter, which is involved in engagement. Okay. So again, coming to a previous year question, this is an ultrasound image which shows the diameter of the fetal head, which is taken as reference for engagement. Which diameter does it refer to? So without even looking at the image, we can see that here they have written a keyword which is reference for engagement, and we know the engaging diameter is always biparietal diameter. So we know our answer, it is A option, biparietal diameter. But in case you want to know, then this bipyramidal diameter is taken at level of thalamus, which is transthalamic level. Okay. So engagement has occurred. Next is descent and flexion. So for engagement, also flexion and descent is important. So this descent and flexion are continuous process. So how does descent occurs? So at least one or more of these four forces are required: pressure of the amniotic fluid, direct pressure of the fundus upon the breech, with contractions bearing down efforts of mother, extension and straightening of fetal body. So on descent, they gave a clinical scenario and asked that which factor is not responsible for the descent of fetus. So they gave a history that a multigravida with gestational diabetes is admitted in labor room, and she has progressed to full dilatation. The vortex hit at -3. And they asked the descent is facilitated by all except. So we already know, yes, that it is not the well-flexed head. So what is the role of well-flexed head? This well-flexed head is involved in internal rotation, but not in descent. Okay. Now, third step is flexion. Flexion is when the head moves towards the chest of the baby. So when descending, what causes about the flexion of the head? When descending, the head meets resistance from cervix, the pelvic wall, and the pelvic floor. So all these three resistance bring about the flexion in the fetal head. After flexion comes the internal rotation. So why this internal rotation is occurring? Because we want to bring our head, which is in LOT position. LOT is left occipitotransverse, and this is the left occipitotransverse is the most common engaging position. So this from LOT position comes into direct occipito anterior position. Okay. So this is internal rotation. So what all are the prerequisites for internal rotation to occur? The head should be well flexed. There should be efficient uterine contraction, and the mid pelvic plane should be in a favorable shape, and the pelvic floor muscles tone should be good. Okay. So internal rotation has occurred. The head has come to direct occipito anterior position. Next come the extension. So what happens in extension? There is a force caused by the uterine contraction, which is in the posterior direction. And there is a force which is caused by pelvic floor and pubic symphysis, which is in the anterior direction. So when we look at the net vector, so the net force is directed toward vulvar opening that brings about the delivery of the head. So by the process of extension, the baby head is delivered. Okay. After the extension of head, there occurs expulsion of the whole body of the fetus. So delivery of the body occurs by the lateral flexion. Okay. So WHO has also given recommendation that how should we deliver the baby head so that the chances of perineal trauma is reduced. So we should give a perineal massage. We should give warm compresses and a hands-on guarding on the perineum. This technique is known as modified Ritgen maneuver. So what we do in this, we use our right hand to squeeze the perineum between our thumb and index finger and use our second hand over the occiput of the head of the fetal head to prevent it deflecting from deflecting abruptly. Okay. So when there is contraction, we use our hand to keep the occiput in an attitude of flexion, and between contraction, we release the head. So there is controlled delivery of head. Okay. So is routine or liberal episiotomy indicated for all patients by WHO? No, it is not recommended. So giving manual fundal pressure to assist in delivery, is it indicated? No, it is also not indicated. After the head is delivered, there occurs restitution. So what is restitution? So for the delivery of head, the the occiput traveled from LOT position to direct occipito anterior position. For this, the neck moved by 1/8 of the circle and the shoulders also moved by 1/8 of the circle. So that movement caused a traction or a torsion in the neck of baby. So to relieve this torsion, the neck moves back into opposite direction to relieve the torsion, and this movement is called restitution. Next is internal rotation. So next is external rotation. So why does external rotation occur? External rotation occurs to bring the shoulders into anterior-posterior diameter. Okay. So to bring the shoulder in anterior-posterior diameter, external rotation occur, and finally the baby is delivered by expulsion. Now coming to certain malpositions, which are brow presentation. So in brow presentation, we know the engaging diameter is mento-vertical, which is 14 centimeter, and this large diameter cannot engage in pelvis. It can't cross pelvis, so there is no method or no maneuver by which vaginal delivery is possible in this case. So mode of delivery is cesarean. Next, coming to presenting part as face. So in face presentation, the denominator is mentum or chin, and the engaging diameter is submentopragmatic, which is 9.5 centimeter. So there are two conditions. First one is when the mentum is anterior, that the chin is anterior. So in this condition, the head can undergo flexion and can deliver vaginally. But what if the mentum is posterior? So if the mentum is posterior, then the brow portion will stuck behind pubic symphysis, and it can't undergo flexion. Hence, in this position, normal delivery is not possible until unless the baby is very small. Next is deflexed head, or what do you mean by deflexed head? That it is in military position. So the engaging diameter is occipitofrontal diameter, which is 11.5 centimeter. This diameter engages, but it fails to undergo internal rotation because sinciput and occiput both lies in the same plane. What is sinciput? It is the brow area. So the brow area and the occiput lies in same plane. So what will happen to this deflexed head? It will depend on the pelvic cavity, whether it is adequate or not, the shape of pelvis, whether it is gynecoid or android, and the contraction strength. So now what happens? The head is in occipital posterior position, and all the conditions which I have just named are favorable. So there the pelvis is roomy, the contractions are good. So the head rotate about 3/8 of the circle and it deliver as occipito anterior. In case the pelvis shape is platypaloid, then the head is able to rotate by only 1/8 of the circle and it undergoes deep transverse arrest. Next, if the contractions are weak and so the rotation will not occur, so head will stay in persistent occipito-posterior position, which is also called as DOP, which is direct occipito-posterior position. So either the face will deliver by face to pubes delivery if the pelvis is adequate, or if the pelvis is borderline, then we have to take the patient for cesarean section, right? So we have covered our mal positions. Now coming to mal presentation, we are short of time, so we'll discuss it in next class. Okay. So only we'll look at transverse lie. So transverse lie, the presenting part is shoulder, elbow, or head. So there is no method by which this baby can deliver unless the patient is not in labor. We can do a external cephalic version and try for vaginal birth. If the patient is not in labor, the patient is in labor, so there is high risk of prolapse, hand prolapse, or limb prolapse. So we will take the patient for cesarean section. WHO has also given certain other recommendations for management of second stage of labor, which include, so what should be the normal duration of second stage before we intervene? For primary patient, they have given a cutoff 3 years, and for multi patient, they have given a cutoff of 2 hours. So what should be the birth position, with or without epidural? It depends on the choice of patient. So if she wants to use upright position or squatting position, whatever she is comfortable in, she can use that position. And what is the method of pushing? The patient has to follow her own urge to push. Okay, so whenever she wants to push, she get that urge, so she will push accordingly. In case of epidural, we can wait for extra 1 to 2 hours after full dilatation, or till the patient regains sensory urge to push. Okay, thank you. I'm done with my class.